Hello, I'm Donna Edwards. I'm giving a presentation on managing depressive symptoms in substance abuse clients during early recovery. Depressive symptoms are common among clients in substance abuse treatment. Findings from a 2001 to 2002 national survey indicated that substance abuse counselors will encounter significant numbers of individuals with co-occurring substance abuse and depressive symptoms. Among people who have had past year contact with health, personnel, or social service agencies and who have had a past year substance use disorder, 40% of those with an alcohol use disorder also had an independent mood disorder, and 60% of those with drug disorder had an independent mood disorder. Depressive symptoms. The term depressive symptoms refers to symptoms experienced by people who, although failing to meet the DSM-5 criteria, diagnostic criteria for a mood disorder, experience sadness, depressed mood, or the blues, and the one or more additional possible symptoms. Here are some depressive symptoms and related feelings and behaviors. The loss of interest in most activities, significant unintentional changes in weight or appetite, sleep disturbances, decreased energy, chronic fatigue or tiredness, feeling exhausted, feelings of excessive guilt, feelings of low self-esteem, low self-confidence or worthlessness, feelings of despair or hopelessness, pervasive pessimism about the future, avoidance of normal, familiar, and social contacts, frequent agitation, restlessness, psychologically or emotionally detached, feelings of irritability or frustration, decrease in activities, effectiveness, or productivity, excessive or inappropriate worries, anticipation of the worst. The nature of depressive symptoms. The term depressive symptoms is generally applied to a mood state of sadness, depressed mood, the blues, or other related feelings and behaviors. Symptoms of depression exist on a continuum. At one end of the spectrum, it is the experience of sadness and other depressive symptoms occurring at appropriate times and for short periods, during which the individual successfully uses coping strategies. At the other end of the clinical or major depression as described in the DSM, clients may have more or less intense depressive symptoms over time. This may be due to the client's biology, stressful events in the client's life, or the client's stopping or starting substance abuse. For example, someone who is drinking heavily may have intense depressive symptoms that seemingly meet criteria for depressive illness, except that the symptoms dramatically lessen in the weeks after initial abstinence from alcohol. Similarly, someone with major depression or dysthymia who is taking antidepressant medications over several weeks may also show fewer or no current debilitating depressive symptoms. As with substance abuse, even though a person may be in remission from a depressive illness, the disorder remains. Prevention of and early intervention in recurrences must be addressed in treatment, especially in early recovery from substance use disorders. Many depressive disorders cycle and reoccur. If a client has a history of mood disorder, the client and counselor should both be on the lookout for a reoccurrence of symptoms. In addition, there are significant individual and cultural differences in how people talk about depressive symptoms. Counselors need to listen carefully to what clients say and probe for clarification. For instance, many people say they are stressed. This could range in meaning from having too much work to a significant symptom of depression. How to distinguish among normal moods, depressive symptoms, and depressive illness. Symptoms of depression exist on a continuum that ranges from transient, relatively brief periods of the blues to major, debilitating symptoms that immobilize a person. The actual symptoms that occur across this continuum are similar but vary substantially in their frequency, their intensity, and the impact they have on the person. When the individual are experiencing normal moods, you might expect the following. A variety of effects are available and can be experienced by the individual. A conversely stated, powerful effects do not have to be blocked or avoided. The range of effects expressed is appropriate to the context and stimuli. Effects can vary over a period of time, such as a day or week. The individual can continue to engage in solving life's dilemmas. The individual does not get into an extreme emotion. Mood swings or the blues are time limited. For individuals experiencing depressive symptoms, the symptoms might be more pervasive, extending beyond an expected time frame. Some effects may feel too powerful to the individual and have to be blocked or distorted, while the effect is expressed might feel normal or appropriate to the person. Others might consider the person to be emotionally over or underreacting. A person will get stuck in an emotion such as fearful or sad and not able to shake it, or he or she may look to an outside influence such as a drug to change the mood. There may be a significant impairment in life functioning areas such as a relationship or work performance. There may be a significant reduction in use of healthy coping styles, resulting in adaptive responses that limit choice or alienate others. There might be a significant negative or pessimistic cognitive bias, resulting in a person seeing life through negative filters. A person might not be able to consistently identify his or her mood or might label an affect in a way that seems confusing to others. For instance, a person may identify himself as scared when he seems sad to others. In addition to the emotional expressions noted under depressive symptoms, someone with depressive illness may be severely limited in the emotions he or she is able to experience, may at the same time get locked into an emotion such as anger, sadness, or anxiety, and respond to almost all stimuli through that emotion, may express emotions in response to stimuli that seem incongruent to others, may recognize that the emotional response is extreme or muted but not be able to change the response, may have significant impairment in most areas of life functioning, may have significantly distorted cognitive functions. The relationship between depressive symptoms and the toxic or withdrawal effects of substances. Intoxication and/or withdrawal from certain substances can lead to depressive symptoms. Depressive symptoms can linger for 3 to 6 months after abstinence and must be treated in counseling. Because appropriate treatments for depressive symptoms have been shown to improve substance-related outcomes, addressing depressive symptoms must be of concern to you as a substance abuse treatment counselor. The relationship between depressive symptoms and substance use disorders. Substance use disorders related to depressive symptoms or a depressive disorder in a variety of ways. Having a substance use disorder increases the risk of experiencing depressive symptoms or a depressive disorder. Similarly, having a depressive disorder increases the odds of having a substance use disorder. Depressive symptoms can result from the direct effects of alcohol or drugs on the central nervous system or from withdrawal of those drugs. Cocaine intoxication and withdrawal can produce symptoms that look like major depression, except that they typically reduce the intensity in a matter of days after abstinence is initiated. As we look at this chart for depressive symptoms typically caused by substances of abuse, the substances for alcohol and the associated depressive symptoms. Alcohol withdrawal has a depressed mood, anxiety, poor appetite, poor concentration, insomnia, restlessness, paranoia, and psychosis. Chronic use is depressed mood and other depressive symptoms. For the opiates, intoxication is low energy, low appetite, and poor concentration. The withdrawal for the opiate use is depressed mood, fatigue, low appetite, irritability, anxiety, insomnia, and poor concentration. Chronic use of opiates is depressed mood and other depressive symptoms. The intoxication for cocaine and stimulants are anxiety, low appetite, insomnia, paranoia, and psychosis. The withdrawal for cocaine and stimulants is depressed mood, increased sleep, increased appetite, anhedonia, loss of interest, poor concentration, and suicidal thoughts. The chronic use of cocaine and stimulants are depressed mood and other depressed symptoms. The intoxication of cannabis is anxiety, apathy, and increased appetite. The withdrawal symptoms of cannabis is anxiety and irritability. Chronic use of cannabis is low motivation and apathy. The intoxication of sedative hypnotics are fatigue, increased sleep, and apathy. The withdrawal of the sedative hypnotics is anxiety, low mood, restlessness, paranoia, and psychosis. Chronic use of sedative hypnotics is depressed mood and poor memory. Untreated depressive symptoms can influence the client's response to substance abuse treatments and the ability to remain substance-free over time. It is important to remember that both problems and their symptoms are primary illnesses and will probably occur without the influence of the other. In this context, an integrated treatment plan addressing both disorders is essential. Sometimes one disorder precedes the other. For example, people who are sober from alcohol or drugs for months or years can later develop an episode of depressive symptoms or major depression. Substance use can cover up depressive symptoms, making it hard to identify depression until a client stops using substances and remains sober for days, weeks, or longer. For example, Steve had been dependent on alcohol for 8 years and drank large quantities nearly every day. He also had depressive symptoms that preceded his alcoholism, but his alcohol use covered them up. Although Steve sought help for his depressive symptoms over the years, treatment was only partially effective because he continued drinking heavily and minimized his alcohol problem. After detoxification, when he began working on a program of recovery, Steve's depressive symptoms actually worsened. Since he was used to reducing his depressive symptoms with alcohol, his mood symptoms caused strong cravings and thoughts for using alcohol. It was clear that in order to help him stay sober, Steve needed evaluation and treatment for his depressive symptoms. Effects of substances on recovery from depressive symptoms. Substance use, abuse, or dependence can cause depressive symptoms to worsen and complicate recovery from a depressive illness. These effects may also interfere with a client's response to medication or other therapeutic interventions. Helplessness and hopelessness are common experiences for clients with substance use disorders and those with depressive symptoms. Having both tends to compound these reactions. Hopelessness and relapse to alcohol and drug use are interrelated. Hopelessness creates a psychological environment that supports drug relapse. At the same time, drug relapse may increase the experience of hopelessness. Suicidality among clients in substance abuse treatment with depressive symptoms. Two populations with the highest rates of suicide are people who are depressed and people with substance use disorder diagnosis. Suicide screenings and assessment scales can be used as aids, but if the client shows signs of being at risk of suicide, these scales are not a substitute for a thorough clinical interview by a qualified mental health clinician, during which client and counselor can talk openly about suicidality. Most clients with suicidal ideation want a path out of their pain without harming themselves. It is their current perception, however, that such path isn't available to them. Some common myths about suicidality include a client will make a suicide attempt if they promise the counselor to not harm themselves. Fact: a variety of circumstances can influence suicidal behavior. A promise by a client not to harm himself may not apply when a client is confronted with a variety of environmental, interpersonal, and psychological stressors. A commitment to treatment plan is generally considered more useful than a no suicide pact. Another myth is talking about suicide thoughts will put the idea in the client's head and make the problem worse. Fact: most clients want to talk about their suicidal thoughts and plans with someone. Talking with a non-judgmental, accepting person about suicide can offer relief. Another fact is changing a client's perception of events in her life will change her suicidality. Fact: events are only one variable in an individual's suicidality. Other variables include the individual's interpersonal support system, psychological variables such as depressive symptoms, depressive illness, despair, and emptiness, cultural values and influences regarding suicidal behavior, and access to a method for suicide. Another myth is a client is not at risk of suicide unless he can describe a plan. Fact: people sometimes impulsively act on suicide thoughts without a well-defined plan. Some do's for working with clients who have suicidal thoughts or plans include: number 1, seek the clinical support and input of supervisors, consultants, and treatment team members. 2. Obtain the informed consent of the client to consult with a supervisor, appropriate mental health professionals, and a referral resources about the client's care. Number 3. Listen to the client's experience and feelings without judgment. Also encourage clients to talk about their suicidal ideation, whether plans have been considered or made, and whether a method, a gun, or medication, for instance, is available. This is important information to have when you consult with a supervisor or mental health professional. Don't allow yourself to be sworn to secrecy about the client's suicidal thoughts or intent. Engage in the client in participating in a plan of care to intervene with suicidal thoughts and/or behaviors. If possible, involve the client's family and significant others in supporting the client. Have a clear understanding of the ethical, legal, and agency guidelines in working with clients who are suicidal. How depressive symptoms affect treatment participation. Depression can affect almost any area of functioning. As a result, the client with depressive symptoms may have problems such as the following: difficulty in concentrating and integrating materials such as program rules and program assignments, trouble keeping appointments, lack of energy to participate in substance abuse treatment program activities such as group therapy, family therapy, 12-step meetings, and recreational activities, lack of perceived ability or motivation to change, belief that he or she is beyond help, difficulty engaging in recovery activities because of social withdrawal, being overwhelmed by feelings, sadness, anger, hopelessness. As a substance abuse counselor, you want your clients to achieve abstinence and an improved quality of life. Addressing depressive symptoms is a part of reaching both these goals. Clients with depressive symptoms may have difficulty relating to other clients. They may see themselves as different and distance themselves from other clients and may not be interested in participating in group activities. The concept of integrated care for substance abuse and depressive symptoms. Integrated treatment for both problems is the standard of care for clients with substance abuse and depressive symptoms or any co-occurring mental disorder. Integrated interventions are specific treatment strategies or therapeutic techniques in which interventions for two or more co-occurring disorders, diagnosis, or symptoms are combined in a single session or interaction, in a series of interactions, or in multiple sessions over time. Look for my training on co-occurring disorders. The application of a number of interventions for depression, including educating clients about depression and depression recovery, integrating counseling for substance abuse and depressive symptoms, understanding depression, reframing from negative thoughts, testing negative belief against reality, helping clients identify and change maladaptive behaviors, developing coping strategies, exploring and understanding emotions related to substance abuse and depression, providing support and encouragement to the client, motivating the client to change. All of these interventions seek to break the cycle of maladaptive thoughts, beliefs, behaviors, and emotional reactions that are characteristic of depression. Here are some brief descriptions of major intervention techniques. Behavioral interventions. Behavioral interventions focus on helping client change problematic behaviors or take on new behaviors that will benefit and sustain recovery. Cognitive behavioral therapy, CBT, integrates principles derived from both cognitive and behavioral theories. Supportive therapy, supportive psychotherapy, the most frequently used psychological treatment in the United States, uses direct measures to reduce or eliminate symptoms and to help the client maintain, restore, and improve self-esteem, adaptive skills, and psychological functioning. Expressive therapies, affecting base. Expressive therapies focus on assisting clients in experiencing and modulating feelings that have been devalued or distorted. Motivational interviewing. The goal of motivational interviewing and related motivational strategies is to assist clients in mobilizing, seeking, and benefiting from a variety of change approaches, as well as to sustain the energy required to achieve lasting change. Choosing among interventions. There is no cookbook that will tell you which interventions to use with a given client at a given point in his or her recovery. Different substance abuse treatment counselors emphasize different interventions and approaches depending on their skills, preferences, and counseling styles. Effective counselors also adapt their toolkits and the specific needs of the client. If you are not comfortable with a given intervention, it is not likely to help your client. Thus, it may be best initially to use a limited number of techniques and expand your toolkit as you gain experience, confidence, and competence. Specific elements of your client's culture may make some interventions inappropriate. Evidence-based thinking. Some counselors may find it useful to think of their work in terms of evidence-based thinking. Evidence-based thinking means picking the best clinical option available for a given client in a given context based on the best current information. The information that is used in evidence-based thinking includes research and experience and recommendations of clinical experts, your past experience, your personal preferences and style, advice from your clinical supervisor, the needs, values, preferences, and characteristics of the client, constraints such as the number of sessions you have available. Evidence-based thinking mixes science and clinical experience with a large measure of common sense. Counselors who use evidence-based thinking are flexible, always looking out for changes in the client's needs and constantly adjusting their approach to make use of new information. Special considerations related to substance abuse treatment setting in which you work. Sometimes responding to the needs of clients with depressive symptoms may require a departure from the way your program normally provides services. For example, clients with depressive symptoms may require more individual attention, and some of these clients will have trouble participating in groups. If your program does not currently provide for extra individual sessions, new arrangements may need to be made. Similarly, some clients may initially feel too low or blue to participate in recreational activities, occupational therapy, or other program components. If participation is currently mandatory, some changes to accommodate people who are depressed might be considered. Special considerations related to the cultures of your clients. Individuals from different cultures and ethnic groups will experience and report symptoms of depression differently. Another phenomenon is that depression is collectively denied by an ethnic group or subculture and therefore is not discussed or reported. For instance, African American women are often socialized to deny the existence of their own needs and feelings and do not acknowledge depression. Some older Americans will talk of having had a nervous breakdown, which for some is another word for depression, but for others, nervous breakdown may mean other psychiatric disorders such as anxiety disorder or an extravagation of schizophrenic illness. Some cultures, particularly Latino and Caribbean cultures, talk in terms of nerves. An ataque de nervios has similarities to a panic attack but is also triggered by a significant loss or distress. An important precursor to cultural competence is self-knowledge. How have your beliefs about functional and dysfunctional behavior been shaped by your own culture? How have racism, discrimination, and cultural stereotyping affected your personality and professionally? How do your beliefs about other cultural groups affect your relationship with clients who belong to those groups? Culturally competent counselors are skilled in framing issues in culturally specific ways. Example given, how does your family respond when you are sad? Recognizing complexity in clients' issues based on cultural context. Example given, how do your experience leaving your homeland and coming to the United States affect your depression? making allowances for variations in relating to others and in use of personal space. Example given, a client's preference for sitting beside a counselor rather than being separated by a table. Displaying sensitivity and culturally specific meanings of touch. Example given, hugging and holding hands. Exploring culturally based experiences of power and powerlessness. Example given, how does feeling depressed affect how you see your status in your community? Adjusting communication styles to accommodate the client's culture. Example giving, permitting comfortable silence in conversations with American Indians. Interpreting emotional expressions in light of the client's culture. Example given, how do people know when you're feeling depressed? What do you do? Expanding roles and practices as needed. Example given, participating in cultural ceremonies, facilitating indigenous support systems, and healing systems. Your professional role and responsibilities in relation to clients with depressive symptoms. As a substance abuse counselor, your professional responsibilities include facilitating and guiding clients in their recoveries through their clinical evaluation of substance use and related issues, treatment planning, counseling individual, group, and/or family, educating, and relapse prevention. If you hold other credentials, you may have a broader roles and responsibilities related to mental health issues. Here is some information on common certifications and licenses for substance abuse counselors and other related professionals, including information related to substance abuse and depressive symptoms. This table is intended as a guideline only. Ethical considerations. As a provider of human services, you take on the responsibility of meeting the needs of your clients to the best of your abilities. This means providing those services for which you have been trained and which the law permits you to provide, and not withholding these services from persons in need. It is also your ethical responsibility to practice within the limits of your skills and the limits of the law. You and your supervisor must make an assessment of your skills, licensures, and certifications as they relate to the needs of the client who uses substances and has depressive symptoms. If for any reason you are not prepared by training, certification, licensure, or other reasons to meet the client's needs, it is your responsibility along with your clinical supervisor to make this clear to clients and to assist them in finding appropriate care. Prepare yourself to work with clients with depressive symptoms. Working with clients with depressive symptoms can be a frustrating and difficult experience for substance abuse counselors. However, helping someone emerge from personal darkness and hopelessness to the light of living well, renewed enjoyment of life, and hope for the future is also one of the most rewarding experiences for the counselor. Let's discuss some of the challenges you will face in working with clients with depressive symptoms and several techniques for preparing yourself to deal with these challenges. While the personal emotional reactions to clients with depressive symptoms can get in the way of effectively using the therapeutic techniques, it should also be noted that understanding your emotional reaction to a particular client can assist you in helping your client. Your feelings towards the client may in fact reflect the client's mood and/or feelings about himself or herself. The common attitudes and beliefs about depressive symptoms. The attitude or belief is if the client stops using psychoactive drugs, the depression will take care of itself. What is known, although this is sometimes true, it is frequently the case that the client's depressive symptoms may be a primary problem in part with his or her substance use. Thus, the depressive symptoms must be addressed directly. The attitude and belief is, this is not my job. I am a substance abuse counselor. What is known to this is your client's depressive symptoms may present roadblocks to recovery. You cannot do your job effectively if you ignore the depressive symptoms. Attitudes and beliefs of, I don't have the skills to work with someone who is depressed. What is known, although working with a client with depressive symptoms does require some special skills, these skills can be learned and used effectively by substance abuse counselors. The common attitude and beliefs about depressive symptoms. An attitude or belief is, I work with the 12 steps. What has this got to do with them? What is known? The 12 steps and the 12-step traditions are powerful tools that ordinary people can use to make important changes in their own lives and in the lives of others. They are effective tools not just for recovery from substance abuse, but also can benefit the lives of people with a variety of other life problems. An attitude or belief with depression is a result of lack of spirituality. What is known about this? Although some symptoms lack of spirituality of depression, especially hopelessness and feelings of isolation, can be addressed by spiritual practices. For many individuals, spirituality alone is not enough. Specific treatment, example giving, talk therapy, group, and medication is needed to relieve depression. Take a look at this diagram on transference and countertransference. You'll see in the middle the self-monitoring, which is the receiving goes in and out, the constraining and the returning to the past, decoding, hypothesizing, verifying hopelessness. It's all about self-monitoring to avoid what's on the outside of the diagram. Countertransference, if recognized, can be used productively in your work with the client. It can facilitate developing an empathetic relationship with the client, understanding the thoughts and feelings you have in reaction to the client, understanding what your client is feeling by understanding your own reactions to your client. Why am I feeling this way? Who am I to the client now? Disentangling the web of your own feelings from those of the client. Countertransferential reactions as you work with clients with depressive symptoms. Clients with depressive symptoms commonly paint a negative picture of themselves, either in words, expressing feelings of worthlessness, hopelessness, inability to cope, lack of competence, or through appearance and demeanor, lack of attention to grooming, listlessness, difficulty communicating. Interrelationships and interactions. Lisa has always struggled with her weight biology. She believes that people don't like her because she is unattractive. Negative belief. She reduces her social contact behavior, which in turn leads her to feel increasingly lonely. Emotion. She deals with loneliness by binge eating behavior, which makes her feel hopeless about herself. Emotion. And supports the beliefs that she is not attractive, so she further reduces her social contacts behavior, which increases her experience of isolation. The perspective of clients with depressive symptoms. Jumping to conclusions. Emotional reasoning. Discounting the positive. Disbelieving others. Black and white thinking. Important ways in which clients differ. Although each person is made up of a system of biology, thoughts, beliefs, emotions, and behavioral predispositions, specifics are what makes us unique individuals. As has been discussed, depressed people tend to share certain characteristics of these spheres. However, there are some important differences which you should be aware. The role of culture was discussed earlier. Following is a discussion of some other differences. Attitudes towards substance abuse and mental health problems. Belief that substance abuse and mental health problems can be addressed. Spirituality and religion. Learning styles. Screening and assessment. Screening and assessment begins at the earliest points of contact with the client and continue throughout treatment. Information about the client's substance abuse and depressive symptoms should be monitored for positive changes as well as evidence that symptoms are getting worse. Screening is a planned and purposeful process that typically is brief and occurs soon after the client presents for services. Assessment gathers information and engages in the process with the client that enables the provider to establish or rule out the presence or absence of a co-occurring disorder. It determines the client's readiness for change, identifies client strengths or problem areas that may affect the process of treatment and recovery, and engages the client in the development of an appropriate treatment relationship. Treatment planning. As a substance abuse counselor, you may be legally entitled to work with clients who have depressive symptoms. However, most states require additional training or credentials to provide treatment to clients with diagnosable depressive illness. Decision tree. How to determine who should work with a specific client. Client-centered integrated treatment planning. A treatment plan for a person with substance use disorder and depressive symptoms should be client-centered and integrated. Client-centered, there is no one right approach to care for the client with a substance use disorder who also has depressive symptoms. Integrated treatment planning is fundamental to providing services to the persons with co-occurring substance use and mental health problems. Treatment planning as an ongoing process. As the client progresses in treatment, new challenges will emerge, new issues may arise, and some initial plans will need to be abandoned. As suggested earlier, a client with a substance use disorder who shows no signs of depressive symptoms at intake may begin to experience depressive symptoms as recovery proceeds. The need to be on the outlook for such changes and the need to further assess when symptoms appear or worsen were discussed earlier. The role of medications. Principles of care. Depressive symptoms must be expected among clients in substance abuse treatment, and this expectation should be incorporated into all aspects of screening, assessment, and treatment planning. Both substance abuse and depressive symptoms should be considered primary. Care for the client with substance use disorders and depressive symptoms should not be limited to a single correct model or approach. Empathy, respect, and belief in the individual's capacity for recovery are fundamental provider attitudes. Treatment should be individualized to accommodate the specific needs, personal growth, and cultural perspective of unique individuals in different stages of change. Clients may at different times have more or less intense depressive symptoms or substance use disorders symptoms but need continuity of care. Skills and techniques: maintaining a respectful, welcoming, accepting, warm, empathetic, hope-inspiring, confident, non-judgmental, trustworthy, and open stance. Setting appropriately frequently and consistent appointments. Listening reflectively. Providing accurate feedback and interpretation. Expressing interest, empathy, and understanding. Actively addressing to misstep or conflict. Setting appropriate limits and boundaries. Being sensitive to the client's ethnic identity, cultural values, and beliefs. Being a good role model. Empathy and sympathy. Empathy involves a heightened awareness of experiences of other, not necessarily suffering, as something to be understood and reflect back. Sympathy involves a heightened awareness of suffering or need of the other as something to be alleviated. The focus is the other person's well-being. Empathy, behavioral concerns, knowing, conceptualizing, understanding. Sympathy, behavior concerns relating, acting for, alleviating, or mediating responses. Empathy is effortful and depends both on experimental and imageal capabilities. Sympathy is relatively automatic and effortless. The self reaches out to the other is empathy. Sympathy, the self is moved by the other. Empathy, the self is the vehicle for understanding and never loses its identity. With sympathy, the other is the vehicle for understanding and some loss of identity may occur. Stages of readiness for change. No perception of a problem and/or no interest in change. Pre-contemplation. Might be a problem, might consider change. Contemplation. Definitely a problem, getting ready to change. Preparation. Actively working on changing, even if slowly. Action. Has achieved stability and is trying to maintain it. Maintenance. Self-efficacy. Partializing a large task into smaller, manageable tasks, setting a modest, if less important, goal that is achievable rather than repeatedly trying and failing at something that is very important but not currently achievable. Mentally rehearsing a task and visualizing success. The 12 steps as a tool. Some of these factors include the support, comfort, acceptance, and hope people find when they enter AA can directly confront some depressive symptoms of alienation, hopelessness, and despair. The 12 steps themselves can be applied to many aspects of healing depressive symptoms. For instance, doing a self-inventory of limitations, as well as strengths and assets, taking action to address wrongs of the past, and the act of reaching out to others can both be curative steps. The slogan and folk wisdom of AA and similar 12-step programs confront stinking thinking that keeps people with depressive symptoms trapped in a cycle of fear and hopelessness. Finally, the non-judgmental acceptance of others in the program provides an environment in which depressed people can examine themselves in a more non-judgmental and accepting manner. Step 1. We admitted we were powerless over alcohol, depressive symptoms, that our lives had become unmanageable. Step 2. We came to believe that a power greater than ourselves could restore us to sanity. Step 4. We made a searching and fearless moral inventory of ourselves. Treatment of depressive symptoms and antidepressant medications. Antidepressant medications rarely have abuse potential. Any given medication has about 50% chance of working well and 50% chance of failing. No method or test will predict the best medication for a patient. It often takes at least 4 to 6 weeks of treatment to achieve the achievement of an adequate dose before an antidepressant medication begins to work. Depression symptoms should be monitored regularly and systematically during antidepressant treatment. If one medication fails to result in a significant improvement in depression symptoms after an adequate trial, generally 6 weeks of treatment at an adequate dose, then a different medication should be tried by the prescribing clinician. Counselors should be alert to possible adverse reactions between an antidepressant medication and the substances a patient is abusing, such as the potential for increased sedation or intoxication. Continuing care and treatment termination. In most cases, you work with the client on his or her depressive symptoms will be time limited. There are some special considerations related to treatment termination with a formerly depressed client, as well as some special considerations for continuing care. Reactivation, preparation, your reaction to treatment termination, continuing care plans.